Okay, thank you very much for choosing to watch this virtual workshop entitled, What Did the Royal Colleges Ever Do for You? We wanted to take a bit of time to explore the role of the Royal Colleges in quality improvement and health services research. I come from a health services research background. I worked for the NIHR, Clark, Yorkshire and Humber for the last 10 years or so, but I've been working for the Royal College of Obstetricians and Gynecologists since July last year. And I was aware of the range of fantastic work and projects done across the 24 Royal Medical Colleges. We've run some kind of joint events subsequently, and obviously there are other colleges that don't have that royal title who are also doing fantastic stuff in this area. And we wanted to have a chance to put in front of health service researchers some of the sorts of work we're doing and reflect on why Royal Colleges might be really useful partners to work with in health services research, and perhaps some of the things that make them good partners. So the basic format for today is that I'm really delighted that we've got 3 colleagues who are going to present their kind of story of quality improvement projects or quality improvement as a whole to you over the next kind of 30 minutes or so. And then we're going to have a chance to kind of respond to kind of 4 reflection questions, and hope that we can kind of plant the seed of the conversation with you. So without any further ado, I'm going to hand over to our first speaker, Liz. Liz is going to do the whole Downing Street advisor thing and ask me to do the next slide as and when. So I will try and make sure that the presentation runs as smoothly as possible. So thank you very much, Liz.
Thank you. Yeah, my name is Liz Saunders. I'm a consultant in emergency medicine and paediatrics at Queen's Medical Centre in Nottingham. And yes, as with most colleges, RChem is responsible for setting standards of training and examination. But equally important element of the college's work is to ensure high quality care in all emergency departments. They do this through the Quality and Emergency Care Committee. The Quality Assurance and Improvement Subcommittee, which I chair, has the responsibility to choose 3 topics for the National Audit Programme each year. And we set the standards, define some quality measures, and produce a national report with some local versions for participating emergency departments, of which there are around 240 across the country. Next slide. So back in 2017-18, the college looked at the results from the recent National Clinical Audit Programme, and we recognised that audit system focused on providing quality assurance and a measure of at a point in time against a set of standards. So here is a slide that shows the pain in children audit, and that's been running since 2003, and it shows the time to receiving analgesia in children with moderate and severe pain as determined by pain scoring. And then the standard set by the college was 100% of children received pain within 60 minutes, but clearly the standard was not met, and there's no evidence of improvement over time. And even worse, there's no noticeable reduction in the performance. There was a noticeable reduction in performance in 2017. It kicks off there. And to the next slide. Thank you. So there came a vision to have a programme that made quality improvement the core of all the change processes within emergency departments. So we wanted to empower staff to believe that they can change practices and cultures, and to engage staff in projects where they felt they had a value and made a difference, unlike in the pain in children where they didn't seem to make a difference. So they decided to do a change to quality improvement projects, and this is tremendously exciting because this innovative new programme was going to allow us as emergency department clinicians to collect data in real time on a weekly basis, and then watch the effects of our improvement PDSA cycles with run charts, and with enough data points, SPC charts, and so to demonstrate some sustained improvement. Next slide, please. So to this end, the new QI platform was tendered, and we decided to use some standards for some previous clinical audits, fever in children, vital signs, and VTE in immobilised patients. And what we did was we took a format that was similar to the previous clinical audits, we collected 5 patients per week. The data collection period was from August to February, 26 weeks, and then there was closure of data to be included in the national report. The difference from clinical audit here was that the data entry of 5 patients should be done each week to produce the rung charts, and the data entry actually doesn't close only for the purposes of the report. And it was felt that the transition from clinical audit to quality improvement could actually be possibly a large jump for many departments. So we wanted to keep a similar process as we've been happening in previous years.
Oh, Liz, your mic's gone off.
So in March, we started the national reports, and this is the official output from the college. And here's an example of the fever in children. So apart from the rung charts, we also included some organisational audit-like data. And this report gives us the opportunity for the departments to showcase their projects and includes a comprehensive explanation of the charts and the interpretation at the end. And this was published in 2019. Next slide, please. So actually, you know, these reports are quite difficult to write, and these, for some reasons I'll come to in the next slide, but for the next quick round came around quickly, and we chose these topics, and 2 from previous audits were mental health and cognitive assessment. But we wanted to do something a little bit more wild. So we decided to do caring children, and we decided to have a joint effort with the Royal College of Paediatrics and Child Health to convert some of their more ED specific questions from their Facing the Future audit, which they published in 2017, into some quality improvement topics amenable to rung charts. And actually we received the first draft of those this last week. There's been a delay obviously with COVID, and they look really promising. Next slide, please. So to come into learning points, as I indicated earlier, the report writing was quite difficult, and this is an example of one of the first charts we received. It shows the combination of data entered from all departments, and the coloured bars indicate some PDSA cycles that the departments were doing, but it was really difficult to understand. And when we initially set up the QI programme, the departments decided they didn't want their data being, their PDSA cycles information visible to the college or to other departments. So we've actually had to take the PDSA cycles stuff out at this stage. But also you can see that it's just a straight line, there's no improvement going on again. And this indicates that either those PDSA cycles were ineffective, or it was only a small number of departments that were doing them, or and their data has been lost in the midst of all of the other data. And there was probably some reasons for this. It's first of all, it's a new system, and departments had some problems logging in, and in fact, actually, as we expected, lots of the departments had some difficulty understanding the process. And the data teams couldn't get the information to them on a weekly basis. So actually they all ended up putting the data in February, and our RChem team actually noticed a big spike of data entry in the last 2 weeks. So there was no sort of continuous improvement going on. And the feedback from them was that they found they were too late to set up their quick teams. And there were some other problems with the actual program itself about charts which had not enough data, and there was a lot of feeling that they were putting too much data in, and it was taking too long. But saying that, next slide, thank you. We had some successes. It was not all bad. VT and immobilizer patients was equipped that the departments could actually engage with, because it was quite clear. It was clear why the audit was being done, and they were preventing DVT and ultimately death from pulmonary embolism in patients placed in plaster casts or boots to their lower limbs. And so they also could work out how to improve the delivery of VTE. So actually you can see more PDSA cycles were done, and actually you can see some improvement in the national report. Next slide, please. So brilliant. Going forward, these are the 2021 topics. We're revisiting pain in children, as we couldn't really leave it as it was. And we're doing fractured neck of femur because there's a drive for better processes in pain management with fascia iliaca blocks. And our president is keen, as part of the RChem National Cares Programme campaign, and in the light of the pandemic, to look at infection control. So we'll probably do something around hand washing. But from the college's effective PDSA cycle this year, we've decided to run the data later, so that from September to March, so that the teams can have their junior doctors can settle in, and they're the guys who normally put the data in, and the teams can see the information, get their data teams to get the data so they can do weekly run charts. And the college itself, we all work voluntarily on the QA&I committee, but we've expanded to include more clinicians and some clinical audit leaders, so that we can actually produce more meaningful measures, and we've got more people to iron out the problems. So great, hopefully there'll be more opportunities for more departments to carry out quality improvement projects that translate to the national picture, and ultimately better care for our patients nationwide. So thank you very much.
Thank you ever so much. That was great. A wonderful start to our trio of presenters this afternoon. And already I'm starting to pick up some things that will be interesting to come back and revisit in the discussion. So I'd like to hand over to Dr. Posey Bidwell next.
Thank you very much. So I'm going to talk to you about the OAC project. So an OAC is an obstetric anal sphincter injury, and is the collective term for a 3rd or 4th degree tear that occurs during childbirth. The OAC project involved implementation of a care bundle as part of a quality improvement project to reduce rates of obstetric anal sphincter injuries in England, Scotland and Wales. The project was a collaboration between the Royal College of Obstetricians and Gynecologists, the Royal College of Midwives, the London School of Hygiene and Tropical Medicine and Croydon University Hospital, with support from our colleagues at King's Improvement Science. The project was fully funded by the Health Foundation. Next slide, please. So why did we do this? So a paper in 2013 found that in the UK, the reported number of OAC tripled from 1.8% in 2000 to 5.9% in 2012. And an OAC can have a significant impact on women's physical and mental health. Short-term consequences include pain, bleeding, infection, and can result in urinary retention and constipation. Long-term consequences include urinary and fecal incontinence, chronic pain, and painful intercourse. Such morbidities can have significant physical and psychosocial burdens on women and affect future birth choices. Furthermore, these have significant financial impact to the NHS through people needing to have extra treatment, and also from medical legal claims. So we do know some of the risk factors for OAC. These include first vaginal birth, South Asian ethnicity, and babies who are more than 4 kilos when they're born, as well as instrumental births. So this is through forceps or vacuum deliveries. But however, for many women, there's no reason why they have an OAC, but research has shown that there are inconsistencies in practice. Things like people practicing hands-on or hands poised at time of delivery, and this can affect the perineum. Next slide, please. So what did we do? So we developed a care bundle which combined 4 evidence-based practices to standardise practice and reduce OAC rates. Implementation of the care bundle was supported by a skills development programme and an awareness campaign. So with our awareness campaign, we had lots of visual things like posters, balloons, pens, which really kind of created a big visual kind of awareness about our project. We also had a lot of stories from women talking about their experiences of what it was like to sustain an OAC. We had a multi-skills development module, which was facilitated by local champions at each of our sites. So we had a local midwifery champion and a local obstetric champion. And we had leadership from both the RCOG and from the RCM. Within this, the project team provided continuous monitoring and feedback, which allowed units to measure their progress. So the study had a step wedge design. We had 16 units in total across England, Scotland and Wales. So the step wedge design meant that the first region started in January 2017, and then 3 months later, this next region rolled out. 3 months later, the next region rolled out until all 16 units were enrolled with implementation. We used mixed methods to understand both the clinical effectiveness of the study, but also we wanted to look at the effectiveness of the implementation strategy. So whether it was acceptable, feasible, what the coverage was, and what the sustainability would be. All the details are published in our protocol in BMC Pregnancy and Childbirth. Next slide, please. So what did we find? So we found that the care bundle was clinically effective and we were able to reduce the rates of OAC. In terms of the implementation outcomes, we did a lot of qualitative work, and within that we were able to identify both barriers and enablers to adoption of the care bundle. So enablers included, so I'll start with the positive things. Enablers included that where there was visible senior level support within the units. So if the head of midwifery or the clinical directors were shown to be very enthusiastic about the care bundle, then people were more likely to adopt it on the shop floor. Another powerful enablers was having very enthusiastic and self-motivated local champions. So these were our midwifery and obstetric champions who were working within the units. We found that actually this really created a lot of team cohesion with midwives and obstetricians working together. Positive outcomes was really great, and more positivity meant that more people adopted the care bundle when they could see how effective it was at producing positive outcomes. Also, we had supportive women. So women would come to the unit and they felt encouraged and they felt supported that that particular unit was doing something to address perineal outcomes. We did also identify some barriers. So we had barriers with data collection. We found it's quite difficult to collect compliance data and fidelity data. And also every unit that we had different data collection systems. So that was very challenging. We had mixed engagement from some local champions, and there was very high staff turnover, which made it very difficult to train all the staff within our units. One of the big barriers was challenging autonomy and professional values. So the care bundle was standardizing practice, which made it difficult for some people to adopt new practices when they had already developed their own styles of delivering clinical practice. Also, we found some people did observe negative outcomes, and this created a barrier for people adopting the care bundle. So we've identified that there were a lack of physical skills, particularly around things like performing episiotomies, and there was resistance to all elements of the care bundle. So there were 4 elements to the care bundle, particularly around what women wanted. And also one of the things we identified was change takes a long time. Next slide, please. So what we wanted to do next was that we wanted to use what we'd learned so far that we could sustain and spread improvement. We were fortunate enough to receive further funding from the Health Foundation, and we're going to use this to implement OAC2, as it's now been called, which has started 2020 and will run until 2022. Within OAC2, the primary shift is going to focus from clinical to implementation effectiveness. So we know that the care bundle works, but now we want to look at ways to make implementation more effective. And with that, we want to be able to produce a locally adaptable and implementation blueprint so we can actually maximize and sustain local uptake and coverage. So OAC2 will have 3 groups within it. The first group will be 10 of our original sites, and the next group is our peer-to-peer implementation group. So they're going to provide support from our OAC1 sites. They're going to become their buddy. So we're kind of decentralizing the support that they will receive. And then our third group will be a lean implementation group, and they won't receive any active implementation support. All 3 groups will receive the same training materials. However, the implementation support will differ. And that's what we really want to try and understand. What's the most effective way of implementing something within a unit? Next slide, please. So what does OAC2 hope to achieve? So we will obviously continue to measure clinical outcomes. We want to continue looking at the OAC rates, but we really want to now understand what the implementation outcomes are. We're going to look again at the acceptability, feasibility, appropriateness and sustainability. And we're going to do that through validated surveys to women to make sure that it's acceptable to them and also to clinicians. With this information, we're going to generate insights about how you can effectively scale up and sustain uptake and coverage within maternity units and develop this implementation blueprint to inform development of future guidelines. Thank you very much.
Thank you, Posy. Super. So, just some contact details there for the current project manager at the college. So our final presentation before we move through into the discussion is Dr. John Dean.
Thank you very much, Dan. So I'm John Dean and I am a physician in East Lancashire and I'm Clinical Director for Quality Improvement and Patient Safety at the Royal College of Physicians. And what I'm going to share with you today is how we've developed and why we've developed the Quality Improvement and Patient Safety Department at the Royal College of Physicians. The College of Physicians' mission is to enable the best possible health and healthcare by high quality care and improving health. And the aim of the Quality Improvement and Patient Safety Department is to make quality improvement and patient safety a core part of professional practice. Next slide, please. Thank you. So in 2013, the Royal College of Physicians published a document called The Future Hospital Caring for Medical Patients. This was the result of a large series of working parties bringing together a future vision of how physician-led care, multidisciplinary, cross-sector integrated care with patients as true partners should be delivered in the future. So this was published in September of 2013 with a real vision of how we would want to deliver care in the future. Next slide, please. At almost the same time, the Berwick report to the patient safety problems in the NHS produced these recommendations, of which number 5 was the mastery of quality and patient safety science, and that this should become part of core learning of healthcare professionals and managers. Next slide, please. So responding to those two outputs, the Royal College of Physicians believed that it needed to demonstrate that by using quality improvement science, we could achieve the vision of the Future Hospital Commission. And so the Future Hospital program was developed and funded by the college. This was a 3 to 4 year program, which had a number of components. The component I'm going to share with you briefly is the demonstration sites. So 8 demonstration sites worked together in 2 cohorts of 4, where they were coached in quality improvement science, came together as teams with patients as partners to try and realise elements of the vision of the Future Hospital Commission. This was independently evaluated by the University of Birmingham and the University of Liverpool. Next slide, please. So this shows some of the results. This is from the Ashford and St Peter's site, and where they developed community hubs for older people. And one of the aims of that was to reduce hospital admissions for older people. And you can see in green on this slide that where the Bedser hub was set up, there was a much slower rise in admission to hospital of older people, frail older people. And that intervention has subsequently spread to 2 other sites in that health and care system. Next slide, please. So the independent evaluation by the University of Liverpool came out with these conclusions, that the Future Hospital programme, through the development sites and other initiatives within that, confirmed that developing quality improvement capacity directly with teams and more widely across the college demonstrated it was possible through that mechanism to deliver some of the vision of the Future Hospital Commission. It also made these statements the centrality of patients and carers being part of improvement teams. We have a patient and carer network who are now a core part of our quality improvement and patient safety department. They also work across the college. Also, that harnessing the national and international prestige of colleges would help to deliver improvements in care through a quality improvement approach, the importance of collaborative learning, and the importance of developing skills for the next generation of clinical leaders through an allied program, our Chief Registrar program, which coaches mid-level trainees in quality improvement in practice. But I'm not going to touch on that further today. Next slide, please. So subsequently, one of the work streams of quality improvement department within the Royal College of Physicians is our breakthrough collaboratives. These are based on the IHI Breakthrough Series Collaboratives, and some of you will know this methodology. Basically, teams of around 4 people within each team, around 8 to 10 teams, come together over roughly a 9-month period, where they come together on 3 learning sessions, and then have some action periods where they're testing and adapting changes around improving care in a particular clinical area. So the aim of the collaborative is threefold. Firstly, it brings together teams to develop their own improvement teams within their own organisations. Secondly, and also network them with other clinical teams working in the same area. Secondly, it coaches them in quality improvement methods and approaches. And thirdly, it aims to improve care in those clinical areas. It's supported by coaching calls, core materials, etc. Next slide, please. So I'm going to show you results from 2 of our breakthrough collaboratives. This is from the Diabetes Inpatient Collaborative, and it's from the Yeovil site, who aim to reduce hypoglycemia in patients with diabetes. And what you can see in their intervention ward is almost an eradication of hypoglycemic episodes while patients are in hospital. And this is a quote from their patient representative, who was part of their improvement team, that they now felt much safer going into hospital if they needed to with their type 1 diabetes. The next slide. This is from the Inflammatory Bowel Disease Collaborative, and this is from the Forth Valley Trust, which was one of the sites, and they were working on having much more effective multidisciplinary meetings for patients with exacerbations and uncontrolled inflammatory bowel disease. And what you can see on the slide is how they work down their backlog and delays in patients, or numbers of patients going through an MDT approach, and also looked at the qualitative elements of that MDT approach, showing definitive improvements. Overall, through the collaboratives we've run, we've seen 90% of sites showing demonstrable improvements over time, not just in the 9 months, but particularly by about 12 to 18 months after the start of the collaborative. Next slide, please. So this is some of our qualitative assessment. This is from the Inflammatory Bowel Disease Collaborative, and you can see the enthusiasm of the teams that participated in that and the benefits that they received in terms of building teams and developing their quality improvement approach, and of course, most importantly, improving patient outcomes. Bringing them out of their clinical site was felt to be valuable and helped to give them time to do this and think about it, but also to build as a team. So our plan this year was to run 10 breakthrough collaboratives in different disease areas, and then COVID hit us, which means that teams of 10, 40 people can't come together in a room for 3 learning sessions. So currently what we're doing is working very closely with IT colleagues to see how we can develop virtual breakthrough collaboratives, which we're aiming to pilot from September. Thank you very much.
Thank you very much, all. So I'm just going to pop the questions that we were going to talk about up on the screen, just to remind ourselves. And I'm going to try and see if I can move back out of this screen and Right, so hopefully now all four of us are on screen. So thank you all very much for those presentations, a really interesting range of work that celebrates the work that the colleges are doing. I think what was really interesting there from John's presentation was that we had a perfect example of that kind of relationship that could happen around between health services research and the colleges. So I'm just going to actually ask a direct question to John first, if I may. So the collaboration with the University of Liverpool to evaluate the programme, how did that start up?
Yes, so that was slightly before my time at the college, but our core approach as a college, and many as with all the colleges, is that we champion evidence-based intervention, and therefore, you know, this was a trial, this was a test to say, would using improvement science actually be able to deliver not only the skills in teams, but also some of the vision of the Future Hospital Commission. And therefore, a core part of the Future Hospital Programme was that it will be externally evaluated by health services researchers. So the University of Birmingham were funded to do that work related to the overall programme, and the University of Liverpool were for that programme, and the University of Birmingham specifically did a further evaluation of the Chief Registrar programme, which was a component of that. So they were engaged at the very start of the whole programme.
No, that's good. Posey, would you be happy to talk to the involvement with the academic partners in Oac and how that came about?
Thank you. So the RCOG has had a long-standing relationship with the London School of Hygiene and Tropical Medicine, which I think is hugely beneficial for both parties, really, because, as John said, having that that ability to be able to completely evaluate what you're doing and produce an evidence base really helps drive practice and drive improvements in practice. So Oac 1 kind of built on that relationship that we already had and that collaboration with the London School of Hygiene and Tropical Medicine. So that was already in place. What was really exciting about the Oac 1 partnership was the involvement then with the Royal College of Midwives, because this is one of the first projects that actually the RCM and the RCOG had worked on together. And it's really fantastic because midwives and obstetricians are working with the same aim of improving health outcomes for women. And so both colleges, you know, it's really great that we're working together to achieve that.
Super. Liz, within the work that you were describing, is there academic input to that?
So we have, as part of the Quality Effectiveness Committee, we have a best practice and standards committee who will try and produce an evidence-based document, and they'll use sort of standard sort of research techniques, critical appraisal and all of that to produce standards and position statements around subjects that aren't covered elsewhere, like they're not NICE covered or they're not covered by any other standards, to help inform emergency departments. And we would use, for instance, the pain in children standards will be used from there, and we will use those for deciding our audit topics.
Okay. I mean, so one thing that health service researchers like is access to data and staff, and so I wonder if we could just reflect a moment why we think that the colleges are particularly well placed. I noted that within the evaluation statements that John put up on the screen, there was the prestige of the college and how that works. How does that pan out when you're out trying to recruit people into working with you in our beleaguered frontline colleagues?
Yeah. So I do feel that is a massive enabler. Of course, what gives us the prestige is if we deliver high quality products and if we give high quality support. So it makes it essential that we have that evidence base around what we deliver and that it is very high quality. Otherwise, that prestige will diminish. You know, particularly for physicians, you know, they pay money to be members and fellows of the college, and they want value and return for that money. However, so I think the fact that it attracts physicians and their teams because it's a professional organisation. However, in terms of attracting partners, I think that's the other key element that the Prestige does. So much of the work that we deliver isn't just through the Royal College of Physicians, it's with academic partners, it's with other professional groups, it's with charities, think tanks, etc. And I see that all of the colleges can be very good conveners of thought leadership, and then demonstrating that it's not just thought leadership, but actually then producing the evidence in practice.
Thank you. Posey, did you want to, you were nodding during the Prestige comment.
Yes, I would definitely agree with what John has said. And when we conducted interviews with clinicians at our sites, so our OAC sites, both the midwives and the obstetricians all said, you know, that it was so exciting and motivating to be part of a project that was being driven by the Royal Colleges, because, you know, the Royal Colleges, particularly RCOG, produces Green Top guidelines, which, you know, we all follow within the maternity unit. So just being able to have that leadership was really powerful. And I'd also agree with what John was saying about it being a great place to convene, because of where the Royal Colleges are placed. It really enabled us to have great kind of involvement with PPI groups as well, being able to have that women's engagement and being able to be that kind of central point where women's groups and charities could convene, so we could get their input into what we were doing as well.
Liz, how are kind of, so within emergency medicine, I know it's quite tricky to identify kind of patient and public involvement folk. How have you kind of brought the end users of your services?
So we do have a public and patient involvement committee, and so basically when we started off here, there were like 4 of us. So there were 4 of us doing these 3 projects and writing those reports, and you know, that's a considerable amount of time. And so that's why I was saying we've expanded our team, and within our expansion of our team, we have got a place for a lay member now that's just been recruited, and we've included clinical audit members, so that we're not just clinicians, because we realise that we need that wider expert knowledge to make sure that we produce something which is much more robust than we may have done with just the 4 of us, you know, struggling along. And I think actually emergency medicine is such a tough subject. We're so busy, there's a lot going on the shop floor, and people don't have that bandwidth to work with the college. There aren't that many people who are keen to work with the college. But as we're doing more of this, I'm getting more people coming up to me going, how can I get involved with this? And how can I come up to the college and do things? So I think the more we produce the quality improvement program, the more the college is becoming more embedded within the departments.
I mean, I think that's probably a really useful thing to think about, that the different colleges are at different stages of the development around this. John, would you be able to comment on that more globally? As I'm going to hazard a guess you've been involved slightly longer than me.
Yeah, I think it's a good point, and certainly I've been doing this role for three and a bit years now, but I've been involved in quality improvement for a long time, and know a number of others well who have been involved in it over the last 15 years, really. My observation is that all of the Royal Colleges are now seeing quality improvement as a core part of their work. There are different elements of that. Some of that is around how we support doctors in training and other clinicians in training in developing these skills, and that is one component. But increasingly what we're seeing is how we bring together teams to actually do improvement in practice, multidisciplinary teams with patient partners in programs such as we've described today. I think the colleges are at different stages of development, obviously different sizes as well, different complexities. We have 31 medical specialties in the Royal College of Physicians, which adds an extra degree of complexity. But I think they've all got strengths, actually. So, for example, Paediatrics and Child Health have run a diabetes collaborative, which has involved almost every single diabetes team in the country over the last 2 or 3 years, with really quite astounding results. College of Emergency Medicine has quality improvement as a core part of their exit process for consultants. We've developed the Chief Registrar program, which we're very proud of. Each college has almost a jewel in this element and its own complexities. So I think we're all developing differently. And I think what's been exciting over the last couple of years is the way we've started to come together to learn from each other and feed from each other as well, to work in the best way that we can for our constituencies.
Yeah, fabulous. I was struck by the kind of duality of some of the things that we're talking around. So quite often, I think a traditional view of colleges is providing evidence, but actually we're all talking about implementing evidence as well now. And so I think that's a rich area for health service research, especially around implementation science, to get involved. And I suppose my reflection on my more kind of recent experience is that the real connection between the colleges and the workforce and education is a real value that no other organisations have within this, and I think can cut across quite a lot of the differences between trusts and NHS providers in giving you that kind of national and potentially global view. Conscious of time, I just wondered if anybody had any final reflections before we bring this to a close. I wonder if there's anything we'd want to say to that audience of thousands of health service researchers who've tuned in just to watch us today.
I think probably one thing that is worth adding is that many doctors, and I can say that because I'm a doctor, have been brought up very much with the very biomedical research elements, but there is an increasing recognition of the pluralist nature of research, particularly social science research, ethnographic research, for example, all the things that are required, that are key facets of wider health services research. So I think that the ground is fertile, really, for that more pluralist approach to what's the evidence of how we're working, how we're implementing, how we're achieving or not achieving the outcomes that we want to achieve.
Yeah.
Thank you.
I think that's definitely right, because when we started the Oac Care Bundle 3 years ago, quality improvement within maternity seemed like quite a new thing, but actually as time's gone by, people have really picked it up and run with it, and they really like being able to have that pragmatic approach to generating improvement within units and being able to use cycles of improvement as well, and just seeing, and that's actually really motivational and really positive to be able to use that. So definitely I think quality improvement's got a really good place now, and I think people are really keen to kind of pick it up and run with it.
Liz, any last thoughts?
Yeah, I sat there and listened to these talks. I'm thinking, we've done our quality improvement program. Our departments are all taking some interest in them, or a lot of them are taking interest in them, and they certainly showed a lot more interest in the second round. So it's just exponential, and I think this is an exponential field, quality improvement, as the trainees get to do more of it as part of their training, and it becomes much more something that you start talking about on the shop floor, and the colleges are all doing it. I think it'll be an exponential rise in people doing that, and we'll certainly see it in our national report. So it's been great. Thank you.
Brilliant. So I guess our kind of clarion call is that the colleges are here, and we are doing stuff that can be researched, and we don't have all the skills to do the pluralistic style research that John's mentioned. So we're always looking for partnerships. That ability of the colleges to convene disparate groups together to kind of take this challenge forward is there. And I think all of us would say that the key thing that we can offer is that link with the staff and those people who are in receipt of the care that we give. Anyway, so thank you all very much for presenting today. Thank you. And I hope that if anybody has any individual queries they want to follow up on any of the projects, there should be some text over there that says how you can get in touch with people. And thank you all very much.
Thank you.
Thank you.
Thank you.